Hi, welcome to Healthcare Delivery Systems Week 12, Parts B and C. Today we're going to look at cost drivers and cost containment. In other words, what are the things that are driving up healthcare cost and what are the things that we're trying to do to control healthcare cost? These are the objectives for this, which you will have in your PowerPoints. And this is the goals for this part. And just a quick review. Costs for healthcare continue to be a large percent of the United States gross domestic product. In other words, of all the money spent in the United States. In the United States, if you recall from previous weeks, we spend more than any other country on healthcare costs per person. This is a concentration of health spending, the total U.S. population up to 2007. We're still at the top. Whoops, sorry about that. So these are the things that are contributing to our high healthcare cost. One is technology and the demand for technology and the increased utilization of technology. The other thing that has happened, we have a large incidence of chronic disease in the United States. We have an aging population, and we have pretty high administrative cost for this service. The Congressional Budget Office estimates that 40 to 50% of our total expenditures are with healthcare. And when they talk about technology as being part of that expenditures, that's the cost of procedures that we do, the equipment that we use, and the processes by which we deliver our care. And as I told you earlier in this course, the expectation from me, the consumer, is we want the best and the latest technology, which continues to drive up healthcare cost. With technology, we have conditions that were previously untreatable, now are treatable. For example, back in the 1960s, even the 70s and the 80s, if you tore a ligament of the knee, you learned to live with the pain because there was nothing to do to fix with it. Now we have new medical and surgical procedures, angioplasty for blood vessel repair, joint repairs, replacement. Our ability to treat has increased. Medical devices and technology that have made an impact. CT scanners were unheard of in the 60s. Magnetic resonance imaging, or MRIs, were unheard of. Implantable defibrillators that would control the regulation or the strength of your heartbeat were unheard of in the 60s. People often died of heart disease. We have health IT or HIT. The electronic medical records have driven up the cost because it's not inexpensive to put these in. Telemedicine is a way to control costs, but it also increases cost as those systems get up and running. Pharmaceutical cost, 10% of our total expenses are estimated to be due to pharmaceutical. And this you can see. Medications for chronic diseases continues to be a factor. And now lately in the news is the increase of those meds for chronic diseases and the discussion, do these meds really cost us high? What is going on in our pharmaceutical industry? Increased demand improves in cancer treatment, improves in cancer chemotherapy, has also driven up cost. Administrative costs, they figure, is 7% of our annual budget. They cost more than twice the average of other countries, and the estimated excess is $91 million. Why do we have increased administrative costs? Because we don't have a single payer system. We have multiple payer systems, which requires much more administrative cost. Physician and hospital cost also keeps driving up our increased demand, utilization. For example, PET scans or positron emission tomography. Ultra-sensitive can pick things up, but they're expensive. MRIs are expensive. Other new techniques that have come, minimally invasive surgeries. One of these is the Da Vinci robotic surgery, where the physician actually uses a robot to go in and perform the surgical procedure. The physician stands outside the room. Those robots are not inexpensive. But why do they use them? Better outcomes, decreases the risk of infection, decreases complications, a shorter hospital stay. So the technology costs money and it saves money. New imaging techniques also drive up cost. Chronic diseases is always a major concern. Chronic disease, those are diseases that people live with and they're managed, but they're not cured. For example, diabetes. Chronic diseases affect 1 of 2 adults in the United States today. Also, deaths due to chronic diseases, 7 out of 10 deaths are due to the complications from these. Your activities of daily living, if you remember back from the long-term care unit, that provides limitations to 1 in 4 with chronic disease, where they cannot function as other people. And the other thing is obesity, the obesity epidemic. They say the generation of children being born today will not live as long as previous generations, and that's due to obesity. 1 in 3 adults are considered obese, 1 in 5 children between the ages of 6 and 19. Chronic diseases and health risk behaviors. 4 risk behaviors identified by the Centers for Disease Control: lack of physical activity, nutrition, tobacco, and alcohol consumption are the risk factors associated with many chronic diseases. Here's an example of a list of chronic diseases. Some of these you're going to recognize. And with chronic disease, you're going to have an increased demand for services. Because why? They need management. They need treatment. It's not something that you just give a medication to and the disease goes away. So you have to avoid treatment. For example, if you don't treat diabetes, you're going to have heart disease. You're going to have kidney disease. You could have eye conditions. The conditions associated with this have to be managed. One thing that you can do: early intervention of risk groups, weight loss, smoking. But the issue with these early groups, unless that person really wants to participate in these early interventions, it's not going to be helpful. They have to want to do it. Early detection and prevention is one way to help reduce costs. So detection, a lot of health insurance plans provide coverage for services that can help detect diseases, such as your screening mammograms. And now they do 3D screening mammograms, which will give you even a better view to see if there's an incidence of cancer. Colonoscopies is a type of preventative services that more health plans are now covering to help but to identify the early onset of disease and thus lower future healthcare cost. Prevention, immunizations is disease prevention. It's also prevention of disease spread in the public health arena. Spending by age group, spending by age group per person. If you look at this age group, look at the cost for under the age of 5, then it slows down. And then as you get older, it keeps growing up. Female traditionally have higher expenses than male. Another increased demand on our healthcare services is our aging population. By Medicare, last year in 2018, from 2011, we had an additional 10 million enrollees in Medicare. Why? The baby boomers came of age during this time period. The projected cost for Medicare is $13,000 per capita, with an comparable increase in Medicare cost. The uninsured. Okay, that is a cost issue because when a person does not have insurance, they don't get preventative care. When they are diagnosed with the condition, they're usually in a more advanced disease state than someone who has health insurance and gets the routine screenings. The other issue with the uninsured is once they are diagnosed, they don't get the same level of therapeutic care as someone with insurance. Their options are not there. The uninsured have a higher mortality rate. The cost of care for an insured is twice as much as uninsured. The uninsured in 2018, in 2010, it was estimated that 15% of the population was uninsured. Look at the difference in 2018. Why is that? Because of the Affordable Care Act, also known as Obamacare, which strove to provide some type of insurance for those who are not insured. Under the Affordable Care Act, if a person cannot afford insurance, the government will provide a subsidy. The government pays the majority of uncompensated care anyway. Also, One thing that's made an impact by the state Medicaid expansion is part of the Affordable Care Act. So for example, in 2018, Iowa had 5%, less than 5% of the total population uninsured, which was a significant improvement. In 2018, the annual spending per person on the uninsured was $2,443, and 1/3 of the uninsured paid that out of pocket. The total spending in the country was $83.9 million, with 12.1% of them being the elderly. But the least likely age group not to have insurance is age 26 to 34. Now think about that. Why is that? Because they're relatively healthy, and if they don't have to buy it, they're not going to. Okay? The average out of cost for the uninsured is $752. One thing that helps to impact cost is EMTALA, and you're going to learn about EMTALA and legal aspects of health information. But EMTALA is the Emergency Medical Treatment and Active Labor Act of 1986. And the reason why this went into effect, it was called anti-dumping legislation. And at that time, prior to 1986, if a person didn't have insurance and showed up in an emergency room needing medical treatment or in labor, hospitals would routinely ship them off to other facilities because they didn't want to deal with them. So it was mandated that if someone shows up into the emergency room needing emergency treatment or in labor, that facility has to care for that person. And not the level of care being admitted, but they have to provide medical screening, okay, and get that person stable before they can be transferred somewhere else. So that was a legal mandate to offer medical care regardless of a person's ability to pay. And anyone presenting to that ER has to be determined, one, if an emergency existed, they had to be treated until stabilized, or discharged self-care or need continuing care. And they could only transfer if a facility capable of providing care if that facility could not do the care. So you couldn't transfer, just get them stable and transfer. Wherever you transferred them to had to provide a level of care that you could not do. So ER utilization on the uninsured. The uninsured poor use the emergency room as a safety net for care. So in 2008, they did an examination of ED use. The percent of uninsured using the emergency room did not change over 10 years. And the non-poor insured with PCP accounted for the most increase in emergency room visits. The overcrowding in the emergency room causes problems because you have to staff it. Lack of staff continues to be an issue. And then the care of people who really aren't urgent causes overcrowding. And then when you have overcrowding, then you have issues with quality and patient safety, because how do you prioritize and get the people in who need the care? Okay, we're going to stop here and then we'll pick up with Lecture C's, and this is going to talk about cost containment methods.